Recently, the Society for Vascular Surgery decided to put together a video archive interviewing many of the innovators and leaders in vascular surgery. And the idea was that younger people could view these interviews and better understand how vascular surgery developed as a specialty. I'm Walt McCarthy from Chicago, and today we have Jock Wheeler with us, who did most of his practice in Norfolk, Virginia, grew up in Virginia, and then became the chief of surgery at Eastern Virginia Medical School, and finally the dean and provost. Welcome, Jock.
Thank you very much.
So you're from Virginia.
Absolutely. I must say I'm from the South, but it's a pleasure to be up here in Chicago. But I grew up in a town called Hampton, Virginia, which is out in what they call Hampton Roads on the eastern border of Virginia near the ocean. And my early education was all there. I went to public high school at Hampton High School, and then went to a place called VMI, which is Virginia Military Institute. And that was the real foundation of my education and of what I became in life because of what I learned there.
Did your parents influence you as far as what field you were going to go into?
I'd have to say yes, because all of my family were lawyers, and that influenced me to do something else. And actually, when I was quite young, I thought I wanted to go to the Naval Academy. So I took the exams and passed the exams, went to take the physical, and I was too short. At that time, I was 5'4", and over the next 12 months, I grew 6.5 inches, but it was too late.
Then along the way, how did you decide you wanted to go into surgery?
I went to the Medical College of Virginia in Richmond, Virginia, to medical school with some idea that surgery was what I was interested in. But when I went to MCV, I went to work for a surgeon in town in Richmond who was a Johns Hopkins graduate and trainee in surgery. And his name was Dr. Thomas Nelson Page Johns. And he was a Blalock trainee. And Dr. Johns influenced me a great deal. And then when I was in medical school, it seemed that every time I went to a surgical program, that's where my interest lay. And so my interest in surgery came about through the time that I was in medical school. And I pursued that and applied for a surgical internship with great support to go to Johns Hopkins. And in those days, the match was a little bit different than it is today, but I put Johns Hopkins first and put MCV second. And when the match came out, I had been pretty much assured that I would go to Hopkins, but I got matched to MCV, which was fine because David Hume was coming there as chairman. But some of the people who supported me were upset that Hopkins hadn't selected me. So they investigated as to why. And it turns out one of my classmates from VMI was in the notebook with his grades on one side of the page and my grades on the other. And when they sent the information to Hopkins, they sent his grades for me, which didn't work out very well.
I see. Oh my gosh. Well, it all worked out pretty well.
It did.
Yeah. So you were an intern in 1958.
That's correct.
And what kind of vascular operations were being done at MCV when you were in 1958?
Well, a little background in David Hume had come from Boston and was one of the pioneers in renal transplantation and had an interest in vascular surgery. So the program at MCV was a very large clinic, indigent-based program with some private patients at the medical college. But we were doing aortic aneurysms, iliac bypass grafts, and the occasional fem pop, above knee type fem pops.
What type of grafts were you using for the aortas?
Dacron grafts.
Dacron grafts.
And used some Teflon in the early days.
Yeah. And so then through David Hume, you became interested in transplant also.
You didn't really have a choice, but yes, indeed I did. And after several years in the residency program, Dr. Hume came to me and said, I want you to go to England. And I said, Dr. Hume, that's all well and good, but I've got 3 little children. I just can't pick up and go to England. He said, oh, yes, you can. And I got a U.S. Public Health Service postdoctoral fellowship to go to Westminster Hospital in London and study with Professor Roy Kahn. And it allowed me to take my whole family, and we spent a year in London, which was an exceptional time in our lives.
And so you were doing kidney transplants.
Well, in London, I did vascular surgery and kidney transplant work. It took me 3 days to get a license to operate on humans. It took me 6 weeks to get a license to operate on dogs. We had an active animal research program while I was there, including heterotransplants and putting kidneys from one animal into another, from pigs into baboons and vice versa. Two little interesting satellite stories is the baboons, after we transplanted them, we put them in a cage, and Professor Kahn would say, Jock, on the weekend you go and dose those baboons with these pills. Well, if you've ever tried to dose a baboon, first I tried putting them in a banana and giving the banana to the baboons, and they would eat the banana and spit out the pills. And finally I went to the head veterinarian at the London Zoo and talked to him, and he said, well, I'll give you something that you can shoot to the baboons, and it'll give you 60 seconds. So that I had to time it so I could open the gate, get in with the baboon, give him the medication, and get out before he woke up. But it was a fascinating time.
So then, in those days, there weren't formal vascular fellowships.
No.
And so where did you learn the real nuts and bolts of doing bypasses and doing vascular surgery?
Well, I learned it in my residency program. In the residency program at MCV, we had approximately 300 clinic or indigent patients on one service for one chief resident. And then you'd have a staff of junior residents. So we did a huge volume of surgery. And when I came out and went into practice, the first night that I was in town, they called me up and said, we've got a lady in her 50s with bleeding esophageal varices. And I did an emergency portacable shunt the first night that I arrived in town.
So that was your first case as an attendant?
My first case right out of residency training. And as you and I know, that's not the way you want to begin, but the lady did very well and survived for a number of years afterwards once we got her off the alcohol.
So when you went into practice, did you do transplant and vascular?
Not initially. I did vascular, and for the first 7 years, I was on call 7 days a week and essentially alone, although I had general surgery partners. It wasn't until 7 years that I was able to find Roger Gregory and bring him to join me. But after we had gotten started doing the vascular work, I went to the hospital administration and said that we need to start a renal transplant program. Our metropolitan area is now about 1.8 million people.
This was in Norfolk.
This is Norfolk, Newport News, Hampton, Portsmouth, Williamsburg, that whole area of Eastern Virginia. And the hospital administrator said, okay, I think that's a good idea. Take this junior administrator and put together a program. So we went out and recruited a nephrologist from Denver to come and set up a renal program and started a kidney transplant program at that time.
Thinking back now, early in your life you were influenced by a number of prominent surgeons, Dr. Kahn, Dr. Hume, others?
Actually, the mentorship goes back a little bit further in that when I was in college, the head of the biology program was a man that was called Colonel Carroll, and he was a one-arm gentleman who had wanted to go to medical school but lost his arm in a sawmill accident, and so he became a college professor. And he would sit in the front of the class and chew tobacco and spit into a spittoon while he was teaching the students, all of whom were males at that time. But Doc Carroll was the earliest mentor I had, who helped me understand that hard work was the key to any type of success. And then later, as I went on to medical school, I was in Dr. Hume's first class of surgical interns. And it was clearly his impact that sustained me through the rest of my career. after I went into private practice, he would call me sometimes at 2 or 3 o'clock in the morning from such unusual places as Chicago or Los Angeles and say, "Jock, what are you doing?" And I learned to say, "Well, Dr. Hume, I'm up reading, just waiting for your call."
Oh, that's good. There were some other people, Dr. Payne, that was in practice when you got to Norfolk that you interacted with.
Dr. Payne was Rogers and my senior partner. He was a general surgeon, and his father was one of the original 30-odd members of the American Board of Surgery. And that practice has existed in Norfolk since the early part of the 20th century. And Dr. Payne was the ultimate Southern gentleman. He was completely honest. You could go to him with any problem that you wanted to talk about and know that you were going to get a straightforward answer. Whether you liked the answer or not was another question. But Dr. Payne, who stayed in our practice until his 70s, was an absolute wonderful person. And he also encouraged me to apply for and be accepted into Southern Surgical, which is a very small group, and as you know, it's not easy to become a member. But on our list, we talked about earlier Dr. L.D. Britt.
Sure, you had a big influence on his career.
Dr. Britt is one of our dear friends, and interesting story about Dr. Britt. And we'll talk about EVMS in a little bit, but when I went to become the chairman of the Department of Surgery, Dr. Britt was an associate professor in the department. Well, 6 months later, when the board asked me to be the dean, we needed a chairman of surgery. So I went to the board and asked them if I could appoint Dr. Britt as chairman of surgery. And they said, "Well, no, you can't do that. He's only an associate professor." And I said, "Well, then, first of all, I'd like to recommend that he be full professor. And after you say yes, then we'll appoint him chairman." And Dr. Britt, as you know, has gone on to be the president of the American College and an outstanding surgical educator.
He certainly is. He certainly is. What was Norfolk like back in the 1960s, and what was your practice like as it developed?
Norfolk at that time was a thriving, stable community, sustained really by the military. There's a huge Navy complex and shipbuilding complex around Norfolk. But in my first year in practice in Norfolk, doing vascular surgery, I did 25 ruptured aneurysms because there were so many people who had not gotten care in eastern North Carolina, eastern Virginia. And at that time, it was all I could do. I kept grafts and blood gas analyzing equipment in the trunk of my car. I kept sutures and operating instruments. And I would go from town to town doing emergency vascular cases.
Oh, I see you. Right. And you'd have them sterilize the instruments when you got there.
I'd have them sterilize the instruments when I got there. I'd draw my own blood gases and take them home. And I had the first blood gas lab in Eastern Virginia.
And then after 7 years, you found a partner.
I did. I found the world's perfect partner in Roger Gregory, who I had known in Richmond at MCV and who had trained with Dr. DeBakey down in Houston and with Jimmy Howell.
And then at what point did you, as a group, decide to have a fellowship in vascular surgery?
About 1973 or 74, we decided that we wanted to start a training program. And at that time, I went to San Francisco and visited with old Dr. Jack Wiley. I went to Atlanta and visited with Garland Purdue. And I went to Boston and visited Alan Callow to talk to them about their programs and how to get started. And we were about the 21st vascular fellowship program in the country, in spite of the fact that we were a very small medical school. We also at that time started a surgical research lab, and we were able to get NIH funding to do some work in the lab, had a PhD working with us. And it was soon after that that Roger started our non-invasive laboratory work.
So over the years, you trained many fellows. One of them was the late Jim Seeger,
Yes.
who was a friend.
And a tragic loss, not only to vascular surgery, but to those of us who were his friends. And Jim was an exceptionally bright vascular surgeon and spent his entire career in Gainesville, as you know, but did outstanding work on the Journal of Vascular Surgery and in other areas. We were fortunate in that we trained vascular surgeons from all around the United States. We only trained, in my time, one female who was sent to us she was from Hawaii, was sent to UCLA to do her general surgery, and then sent to us to do a 2-year vascular fellowship to go back to Honolulu. But we have surgeons that we trained in all different parts of the country.
Many of the papers that you've written are about interesting technical concepts because you were doing so much clinical surgery, and you became interested in composite grafts using prosthetic combined with vein grafts. How did that occur to you?
Well, as most people know, back in the early days, all peripheral surgery was above the knee. And for the most part, it was Dacron, fem above knee pop type bypasses. Mm-hmm. And it became clear over time that we had to go below the knee to salvage more extremities. And in those days, the cardiac surgeons were taking a lot of the veins, and there would be patients that didn't have enough vein to be able to go below the knee or down into the tibial region. So that we started working with the concept of using a piece of prosthetic material on the proximal portion and using segments of vein below that.
Did you use the prosthetic piece as a femoral popliteal bypass and then bypass off of that, or did you put them together end to end at the knee?
We put them together using a end-to-end technique for the most part, rather than doing a jump graft where we'd go AK fem pop and then go below the knee that way.
Which was, and many people use the jump graft technique, but you had very good success using the end-to-end technique.
We did.
Yeah. Are there any tricks to making that work?
I think heaven creates the tricks because you can salvage a number of extremities that you would otherwise lose by using these techniques, but it was unpredictable to us which ones would actually do well and which ones wouldn't. Clearly, the better the runoff setup, the better your chance of success.
Another interesting topic that you worked on was the design of certain surgical clamps, vascular clamps, the Profunda clamp, for example.
Yes, and Dr. Roger Gregory was and still is very innovative, and Roger spent a lot of time working on instrument design, and the Profunda clamp was a design that he worked out and actually created the first Profunda clamps before they were made in a mass production in the marketplace.
Back in the 1970s, PTFE was beginning to be developed as a bypass material, and you actually were involved with implanting probably the first femoral popliteal bypass. And Roger Gregory is with us today so that you can talk about that historical experience.
Well, I'd been in town with Jock for about less than a year, actually, after I'd finished my fellowship, and we had a patient that came into the office with a critical ischemia of the leg, an elderly diabetic lady with rest pain, and the problem was she already had her saphenous veins removed for varicose veins. So we brought her in the hospital and angiogrammed her, and she did have what looked like a reasonable popliteal segment below the knee. Well, a few months before that, we'd used a PTFE graft by another manufacturer, and we did, I think, a tibial bypass. And post-op, the graft thrombosed, and we went to do a thrombectomy, took her back to the operating room, and the graft split from top to bottom.
You were using a Fogarty-type catheter,
Right.
balloon catheter.
Put a balloon catheter in. When we drew it back, the graft split. So we were not very excited about using another PTFE graft. We felt like we couldn't use a Dacron graft. We'd use that in my fellowship and primarily in the AK position. Certainly below the knee was not a very good situation. So we were in a real dilemma as to what to do with this patient. we heard rumors that there was another company, the Gore Company, making a PTFE graft. So I don't know whether I should say this on camera, but as Jock used to say, I would call Jesus if I could just get his phone number. So I got the phone number for the Gore Company and called up, and a guy named Jack Hoover answered. And we talked about the problem we had, and he said, oh, fine, we've got a graft that I think you can use. It's FDA approved, and when you need it. But then I said, but now wait a minute, we're worried about burst strength, and they called it hoop strength. And he said they'd solve that problem, the Gore Company, by using an external film or coating on the graft. So I went back to when do we need it, and I said, well, right now. And he said, well, how about tomorrow morning? And he flew all night and brought us the graft.
He was in Flagstaff, Arizona.
He was in Flagstaff, Arizona. And when we looked at the graft, we felt like it was a little stiffer than we wanted, but it wasn't saphenous vein, but it looked very reasonable. So we said, okay, fine. Next couple of days, he had us 6 of them to use. August the 25th, 1975, we took this patient to the OR, and we did a femoral to below knee popliteal bypass. Patient did well, and we thought it was just not that unusual. We had a difficult problem was solved, we went on to the next patient. Later I found out from Jack Hoover that this was the first graft they had sold, and subsequently they have sold 5 million of these grafts.
Mm-hmm. Was it a 6 millimeter graft?
6 millimeter graft.
Oh yeah.
I remember we used a 5-O-proline on an RB1 needle for the distal anastomosis, and when we opened the clamps, it was like a watering pot came out. Well, we were just almost panicked. We didn't know whether it would stop or not, although we had a similar problem with the other graft that we'd used. And we reversed the heparin quickly and put on some hemostatic agents, and finally with a little patience it stopped. And we learned after that was more or less routine. But this was a very exciting time for us, certainly for me. I'd never heard of PTFE when I was during the fellowship.
Was Jock there with you when you for that first case?
Absolutely. I wasn't that busy the first year. It kind of got out of hand after that, but the first year I used to scrub with Jock all the time, and vice versa. He would keep me out of trouble, and I had a lot of experience being an assistant in Houston, so we scrubbed together all the time then.
I'll quickly tell you one story about Roger and I scrubbing together. My father, I was getting ready to go to a surgical meeting, and my father called me and said he had a pulsating mass in his abdomen. He was a lawyer, and it wasn't necessarily, they weren't related, the mass and being a lawyer, but he called, and so I canceled my trip and called Roger and said, you know, my dad's got probably a leaking aneurysm. And so the family got together, and we were sitting in the waiting room, and Roger went in to operate on Pops. And pretty soon I got this phone call, say, would you come to the operating room? And we had encountered a ruptured inflammatory aneurysm, which Roger has not seen before.
No, I had
And
not.
so we operated on my father and fixed it, and he lived for quite a number of years after that.
I remember the OR nurse and the supervisor came running in and said, you know, Dr. Wheeler can't scrub on this. And I said, well, if he doesn't, we're going to kill his father. Because I've never seen anything like it.
Oh boy. So then you went on to use PTFE for carotid patching,
Yes.
and what about that?
The Gore Company came out with patch material that we thought was very attractive, and I liked it off-the-shelf feature, and we began to use it very frequently for patch material, both there and in the groin and other places. Also, the supplement came out with the Gore suture that was more one-to-one with the needle, so that the watering pot was not quite as active when you took the clamps off. But we found it to be a very satisfactory material.
We used to use pieces of the bypass graft for patches. You probably did the same thing
Yes.
before they came
Before
as
they came out with the
packaged.
thin wall,
That's exactly
flexible
right.
material.
Right. Well, Roger, thank you so much for
My pleasure.
telling us that whole historical story about the first bypass graft.
My pleasure.
Jack, more recently, you have become interested in endovascular treatment of vascular disease.
Yeah, our interest in the endovascular work really goes further back in that when I was in residency training, I worked in the research lab with the cardiothoracic surgeons and learned how to do cardiac casts, first on animals and then later on humans, so that doing angiography was something that I was raised with. And when I came to Norfolk, there were no angiographers in Norfolk. So I did all my own angiography. I did translumbar aortograms and developed a cath lab so we could do catheter techniques, and later recruited angiographers for the hospital so that they could do, the regular patient type work. So that handling catheters and needles and sticking holes in blood vessels was not foreign to us at all. And we early on developed techniques where we were using stents to treat iliac lesions. And just a fun story along that line, I went to Toulouse, France a number of years ago to give a paper as a vascular surgeon at an international radiological meeting on putting stents in the iliacs and then doing distal bypasses on the same patients. They were not terribly happy to have me there, as it turns out, and it was a bilingual meeting in which it was either translated into French or English. And at the end of my presentation, I had a little video. Well, when it came time to put on the video, I couldn't get them to turn it on. And the response was, no speak of the English. And the radiologists were upset. But we were involved in that type of work early on, so that moving from Peroti's work, moving into the endovascular side was a natural thing for us in our practice. And the cardiologists attempted to get into that type of work, as did the radiologists. But because we had the dominant vascular referral base, our people developed that technique. When I went to the medical school full time in 1994, that's when we were really moving ahead with the endovascular work. And now the vascular practice at home does by far the majority of the work.
You have always been interested in surgical societies and the Southern Surgical and regional vascular societies. Tell us what you think the importance of those regional societies are. You were the president of the Southern Vascular and the Virginia Vascular Society.
It is an important educational forum for the people who do vascular surgery, not only the fully trained board-certified vascular surgeons, but for all those others who do vascular surgery to be able to go to a place where vascular subjects are discussed and openly discussed. And so I was president of the Southern Association of Vascular Surgeons and was one of the early participants in that group when it was organized. And also we put together, mostly with Stan Snyder from our group, Roger Gregory and myself, the Virginia State Vascular Society. And I think it's been critically important as an educational forum.
You also have been very involved with the Eastern Virginia Medical School, which was started in 1974. And then how did you become the chief of surgery to start with?
And that's a little bit of a long story. I wanted to stay in academic surgery, and actually went and interviewed with Dr. Ben Eisman, who recently passed away, at the University of Kentucky, and was going to go there. When I found out through some friends that they were in the organizing stages of putting a medical school in Norfolk. And it seemed to me that it was the perfect place to go to be able to practice vascular surgery and build a program, and also to be involved with the development of a medical school. In vascular surgery in that community, there was an old, slightly crippled general surgeon named Lowenberg, who was doing vascular surgery. He had gone to France with Kuhnlin and some of the early people. He was making nylon grafts out of his wife's underpants. And when I first got there, he came and asked me if I would scrub with him. So for about 6 months, every time he had a vascular case, I would go, and these were usually aortic cases. And later it became apparent to me that when we would get down to the point of sewing in the grafts, Dr. Leuenberger would always say, "Jock, you go ahead and sew it in." Well, this has been going on about 6 months, and I was really enjoying it. And he came to me one day and he said, "I have to tell you, I have bad cataracts, and I've got to go up to Hopkins and have my eyes operated on." So he'd been essentially blind for that 6 months that I'd been operating.
That's why you were sewing the grafts in.
But I was getting to sew in the grafts and see the patients. He got up to Hopkins the night before he was to be admitted. He had a heart attack, and his wife drove him back to Norfolk, and we admitted him to the coronary care unit, and he arrested while I was standing at his bedside. And back in those days, we gave him bicarbonate, which was the big thing to give people who became acidotic. He woke up the next morning, first thing he did is look up at me and say, "Did you give me bicarb?" And he subsequently passed away, but he was the person who was the only person who was doing vascular surgery in our community. So I put together a division of vascular surgery in the early days of the medical school and a vascular research lab. We also organized a vascular intensive care unit and a non-invasive vascular laboratory program. So I was in a private corporation, but was a faculty member in the early days of the medical school, and actually chaired the first committee to assign faculty rank to all the community faculty. And if you think that was popular, you can imagine. But later in the early 1990s, our long-term chairman of surgery retired, and I was involved with the search committee to pick a new chairman. And unfortunately, the new chairman that came had some substance issues and had to be removed from his job. And the dean and the school came to me and asked if I would come full-time and be the chairman of surgery and oversee all the surgical education programs as well as the multiple surgical disciplines. And wisely or unwisely, I agreed to do that. And at that time, we also appointed a new dean who was a lady. And unfortunately, that lady, after 6 months, was asked to leave. And the board of the medical school and the president came to me and asked if I would take on the job of dean and provost as an interim. And I said, no, I won't take it as an interim. If I'm going to step into that bailiwick, I'll either have to be fully appointed to that job or I can't do it. So they did, and I spent 5 years as the dean and provost until my wife and children asked me to come home.
What about combining the provost and the dean's job? That sometimes those are separate jobs at medical schools.
It worked very well for us because our president was a layperson, and as dean and provost, I had responsibility for all of the programs, and everyone in the system answered to me, and then I answered to the president, who was a layperson, and the board. And so in our program, that worked very well. The school has now fortunately transitioned so that the new dean and provost is also going to be the president. And in a school of our size, we have about 110 medical students per year and about 350 residents. In a school that size that's community-based, that's, I think, the best way to approach it.
Tell us a little bit about your family.
I have 5 children that range from 23 to 53, and I have 13 grandchildren, and I have 2 great-grandchildren. And my wife of more than 30 years, who, as I told you, is a master's prepared nurse and an attorney, has been the foundation of my life and kept me sane through the time in the dean's office. They used to ask me in the dean's office if it wasn't stressful. And I said, no, stress is when you operate on somebody and they die. This is just frustration.
That's right. That's a pretty good analogy, actually.
But we have a very large and fun family, and my time today is spent mostly with family-type activities.
Tell us about your hobbies and sports that have kept you happy over the years.
I grew up, my father, in spite of being a lawyer, was a very accomplished golfer and taught me to play golf when I was very young. And I didn't play at all through college and medical school and training. But in retirement, I have found that it's a great outlet for me. And I have a large group of friends at a club where I play golf, and I've enjoyed that greatly. They also, for the good or bad, when I retired, they asked me at that club if I would go on the board and then take over as the president of the board while we tore down the clubhouse, built a new clubhouse, and redid the golf course. And that occupied me for 4 or 5 years and was great fun.
So you got to redesign the golf course.
We did.
Oh, yeah. Sounds like fun.
I also, I love the outdoors, and I love plants. We do orchids in the house, and last year I built a greenhouse. And so I have no trouble finding things to do and being entertained.
I wanted to ask your opinion about the training of future surgeons, particularly related to the open techniques, that, as we know, are probably harder than some of the other techniques. And with the laparoscopic surgery and endovascular surgery, how are we going to train people to be good open surgeons?
It's I think, a huge problem for the future. Vascular surgery was a fun time in my life. I can't say that I had an unhappy day. I had unhappy moments, but not unhappy days. And I used to, on the lecture circuit, talk about the fact that vascular surgery will never go away because we have McDonald's and Hardee's and all those people who keep serving our children fatty fast foods. But the reality of training vascular surgeons, I was involved back when Bob Barnes pushed hard for changing the vascular fellowship program and making it part of the general surgery training where you could opt out after several years and do either thoracic or vascular as an emphasis. As I talk to my friends, I think vascular surgery's future is in some jeopardy. Not only are we going to have trouble training the young surgeons to do open surgery, we're going to have to train them to do the endovascular work, which is the primary way vascular disease is treated today. But we also have the issue of vascular surgery is difficult, intense, and time-consuming. And you're not rewarded in that fashion in today's environment. And we're seeing now that the young people, if in the surveys, they don't want to go into vascular surgery. It's too time-consuming. They're not reimbursed strongly enough. And it means that what we're turning out is a different product than we had before. So I think there's great jeopardy, but the jeopardy is also on the general surgery side. As I talked to LD Britt, they have the same issues in general surgery. Most everything is being done with scopes. And yet there are times when you have to be able to go in and do the open work, which those of us who are a little bit senior, that was our bread and butter. So I think there's great jeopardy. It's going to take very thoughtful consideration by the senior leaders to see what are we going to do with the vascular fellowship programs and the training of people to do vascular surgery.
Well, Dr. Wheeler, thank you very much. It's been a real pleasure talking to you and getting your insights
Thank you
here
all.
in Chicago.
I appreciate being here.